In this segment, we're going to start talking about the two major categories of lung disorders, the restrictive and obstructive lung disorders. Actually, we can categorize almost all lung disorders into restrictive and obstructive. And actually, an easy and nice way to understand the mechanisms and the differences between restrictive and obstructive lung disorders, if we think of this cup of Pepsi with the this straw coming out of it. So what is it, if we can call it, what is a restrictive cup disorder, a restrictive cup problem? Now, one of two things can happen and ruin our experience of drinking Pepsi out of this cup. The first thing is if the capacity of the cup is reduced. If something from outside distorts the cup, or if you have a tight rubber band here that squeezes the cup, decreasing its capacity, or if you have something inside the cup, again, reducing its capacity to accommodate Pepsi, like if you have a lot of ice cubes, or maybe if you have a paper towel inside the cup, all these things would limit the amount of Pepsi that you can get into the cup. Here, in these conditions, when something is restricting the capacity of the cup, what's your difficulty? To get Pepsi in or to get Pepsi out? Your difficulty is to get Pepsi in. So what we can call restrictive cup disease means you're unable to fill the cup with Pepsi. You're unable to get Pepsi in the cup. Let's apply this to the lung. A restrictive lung disease means you are unable to fill the lung with air easily. Did we talk about that before? Yes. That's poor compliance. Poor compliance. So the problem in restrictive lung disease is you cannot get air in. That's the problem. You cannot inhale. You cannot inhale, or you need to apply a lot of pressure to inhale. Give me example of a restrictive lung disease, pulmonary fibrosis, and here because of the poor compliance, you inhale with difficulty, you get air in with difficulty. Give me another example of restrictive lung disease, pulmonary edema. So in restrictive lung disease, and by the way, the restriction can be due to causes inside the lungs, like fibrosis and edema, but the restriction also can be due to causes outside the lungs, like what? Think of severe musculoskeletal deformities, like severe kyphoscoliosis. This will limit the lung capacity. Think of muscle paralysis, like myasthenia gravis, weak muscles, or think of diaphragmatic paralysis, or think of something inhibiting the respiratory center. Again, all these are extrapulmonary causes of restrictive lung problem. Now, what's an obstructive cup disease? If you have a normal cup and nothing is restricting it, and you don't have paper towel inside, and you don't have too many ice cubes inside, and the cup is full of Pepsi, but instead of having this normal caliber, nice straw, let's say they only gave you this tiny coffee stirrer. It still has a lumen, but imagine yourself trying to get Pepsi out through this very, very, very tiny straw. That will be a problem. Now, the cup is full of Pepsi, and you are thirsty, and it's hot outside, but your problem is you cannot get Pepsi out. You cannot get Pepsi out. So let's apply this to the lungs. Obstructive lung disease means there is air inside the lungs. There is air inside the lungs, but because of bronchoconstriction, So the bronchi, instead of, I think I got, yes, here's another straw, the usual straw. So let's compare. So let's compare this straw with this one. That straw, that's the normal bronchi. That's the normal caliber of bronchi. You can get air easily out of this. You can get air, you can get Pepsi easily flowing in this kind of straw. But with this one, you will have great difficulty getting Pepsi out. So in obstructive lung disease, because of bronchoconstriction, you cannot get air out, okay? And you take long time to exhale, longer time to exhale. So you exhale slowly and incompletely because you try to get air out as much as possible. You do a lot of effort to get air out. Example of obstructive lung disease, asthma and COPD. Asthma and COPD. Okay, so restrictive lung disorders characterized by decreased compliance, poor compliance, which means you need to do more effort, apply more pressure to get air in. So it's mainly a problem of getting air in. Patients complain of dyspnea. By the way, any lung disease will result in dyspnea. Any lung disease will result in shortness of breath. And here's the thing. What is the major symptom of restrictive lung disease? Dyspnea, shortness of breath. What is the major symptom of obstructive lung disease? Dyspnea, shortness of breath. What is the major symptom of any lung disease? Dyspnea, shortness of breath, which means clinically, you cannot tell them apart. Clinically, you cannot tell restrictive and obstructive lung disease apart. We need to do pulmonary function tests, and this is what we're going to explain in a minute in this segment and in the coming segment as well. Restrictive lung disease can cause ventilation perfusion mismatch, and we're going to explain it again in a coming segment, leading to hypoxemia. Examples of restrictive lung diseases in adults. We talked about pulmonary fibrosis. We talked about pulmonary edema. ARDS is also a restrictive lung disease because it causes atelectasis, it causes collapse and aspiration of into the alveoli, aspiration of whatever gastric contents, for example, into the alveoli. Also, we can have disorders outside the lungs and resulting in restrictive, like scoliosis, excuse me, deformity of the thoracic cage, obesity, like in obesity hypoventilation syndrome, paralysis of respiratory muscles, whether myasthenia gravis or diaphragmatic paralysis. On the other hand, obstructive lung disorders, there is airway obstruction, bronchial narrowing, and usually the bronchi are usually narrower during exhalation. So if you have any degree of bronchial narrowing, it's going to affect exhalation first before inhalation. And now you need to do more force and you need more time to exhale a given normal volume of air. The unifying symptom of obstructive lung disease is dyspnea, same as with restrictive. But the unifying sign here is wheezing due to bronchial narrowing. And we will talk about the pulmonary function tests in a minute. And the most common examples of obstructive lung disease, asthma and COPD. And COPD is a combination of chronic bronchitis and emphysema. You will always have these two together in any COPD patient, chronic bronchitis and emphysema. Okay. Let me use now the whiteboard to talk about the pulmonary function tests. unlike the lab tests, we do not have a standard normal values for pulmonary function tests. We have custom made or custom values. And we consider this normal for you. So it's individualized. And we call them the predicted values. Based on your what? Based on your age, based on your gender, based on your height. Okay? So based on your age, gender, and height, you will have your normal values. And what's the passing score in this course? It's 80%. If you get 80% or more, you pass. If you get less than 80%, you fail. What's the passing score in pulmonary function tests? Again, the passing score is 80%. If you score 80% or more of your predicted values, you pass. You have normal pulmonary function tests. But if in any pulmonary function test you score less than 80%, this is abnormally low pulmonary function tests, and we have to know what's going on. Okay, so to begin with, the pulmonary function tests, the normal values differ from one person to another, depending on the person's age, gender, height. Age, gender, height. By the way, what seems to be missing here? Age, gender, height. Do you think you want to add a fourth parameter to determine your normal predicted values? Do I hear someone say, where is weight? Weight. Weight cannot be one of the parameters that determine the normal pulmonary function test values for you. Otherwise, obesity hypoventilation syndrome wouldn't be a disorder. In pulmonary function tests, we assume your ideal body weight. We assume your lean body mass. We assume your ideal BMI. So obesity will result in poor pulmonary function tests because obesity causes obesity hypoventilation syndrome. So the only three factors that determine your predicted value are age, gender, height. That's why when you go to the spirometry unit, and by the way, pulmonary function tests are very tedious tests. They are very exhausting and they require a lot of cooperation. So if there is, so we don't do pulmonary function tests for young children. They are not going to tolerate it and they will not be cooperative. We don't do pulmonary function tests if we have like kind of a language barrier and the patient is not cooperative. Any patient who cannot be cooperative cannot do pulmonary function tests. And as I mentioned, the passing score in any pulmonary function test is 80%. Less than 80% is an abnormal pulmonary function test. We usually have two tests. We usually do two tests to differentiate between restrictive and obstructive. And these two tests are the forced vital capacity and the forced expiratory volume in 1 second. So what's the forced vital capacity? We want to know how much air we can fill your lungs with. So how do we measure it? it's much easier to measure the volume of air that fills your lung if we can get it out and then measure it. And this is what we do. So we ask you to inhale as completely and maximally as possible. Then we ask you to exhale as forcibly and as completely as possible. And as you exhale, we collect and measure this volume of exhaled air after maximal inhalation. So the forced vital capacity is volume of maximally exhaled air after maximal inhalation. That's the forced vital capacity. Okay? Again, forced vital capacity for each individual is first calculated based on your age, gender, and height, and we give you a value. We say this is your predicted value. This is going to be considered our 100%. Okay? Let's do the test and see how much you're going to score. And we call this value the predicted value. So the predicted value will be your absolute, will be your 100%, will be your best. Okay, let's see what you're going to do. Some patients just get the 100%. Perfect. You pass with flying colors. Some patients get 70% of their predicted value, predicted based on their age, gender, height. Age, gender, height. If you score less than 80%, you fail. And then we say you have abnormally low forced vital capacity. Okay, what's the forced expiratory volume in 1 second? This one means 1 second. How do we calculate it? Simple. As we collect the forced vital capacity volume, we calculate the time. How much time? How many seconds you take to exhale maximally following maximum inhalation? How many seconds you take to exhale maximally following maximal inhalation? And we divide the forced vital capacity by the time in seconds, and we get the forced expiratory volume in 1 second. So the forced expiratory volume in 1 second is the volume of air exhaled in 1 second. Again, there is a predicted value for this based on your age, gender, height. If you score 80% or more of the predicted value, you're good, and you have normal FEV1. If you score less than 80% of your predicted value, you have abnormally low FEV1. Who needs more time? Who needs more time to exhale? A patient with restrictive or a patient with obstructive? Or in other words, this FEV1 is it longer when the bronchi are narrow? This FEV1, sorry, is it lower when the bronchi are narrow? So tell me about the FEV1 with a bronchus like this or a bronchus like this. Here the FEV1 will be high because the volume of air exhaled in 1 second here will be very high because the bronchus is wide open. But with a narrow bronchus, the FEV1 will be very much reduced. So the FEV1 is the best test that correlates with the bronchial diameter. Okay, the FEV1 is the best test that correlates with the bronchial diameter. I'm gonna end this segment here, and in the next segment, we're gonna talk about how we utilize the pulmonary function tests to differentiate between restrictive and obstructive lung diseases.